The mitral valve is more than just a valve, as you guys know better than I do. It's a entire apparatus that has multiple components. The annulus is the anatomic sort of line between the atrium and the ventricle. The leaflets are shown here, the anterior and posterior leaflets. And then the cords, and there's sort of breakdown of the cords, the primary cords along the leaflet edge, the secondary cords that are sort of attached right into the leaflets themselves, the body of the leaflets, and then the tertiary cords, which are more basal. The papillary muscles to the anterolateral and posterior medial. And then the ventricle itself is intimately involved in the function of the mitral valve, as we'll see. So here's a sort of video showing a heart that's been replicated into systole and diastole, and what you can appreciate is a couple things. It's not just leaflets that are opening and closing. During diastole, the ventricle enlarges. These cords pull down the leaflets and open it up, and during systole, there's a lot of tension here on the cords to prevent them from prolapsing or opening up so that you can retain the forward flow of blood. And when more of a short axis, you appreciate that it's not just the leaflets opening. The annulus is enlarging during diastole so that you can optimize and really get as much blood flow from the left atrium to the left ventricle. This always confuses my kids. They think I'm looking at like a bird or something, and it's kind of a weird picture here. Getting a little bit more into the anatomy of the leaflets, there's the anterolateral commissures and posterior medial. The anterior leaflet is attached to about 2/5 of the annulus, and the posterior leaflet is the other 3/5. The leaflets are divided up in these little indentations, which end up divvying them up into various scallops. So you have the A1, P1, A2, P2, and A3, P3. And these are important distinctions when it comes to what you guys do as far as repairing or replacing them, but also defining the pathophysiology and what's actually going on here as a disease. Further sort of distinctions and unique characteristics about the mitral valve that are important for any sort of surgical intervention include the intervalvular trigone or fibrosa here between the aortic valve and the mitral valve. Also knowing what else is in the neighborhood, particularly the circumflex artery, which, if you have a dominant left circumflex artery going around the AV groove near the mitral valve, it's just for you guys, and we've seen this, have to be very cognizant not to disrupt the integrity of the circumflex when you're repairing or replacing a mitral valve. And then there's no real sort of fibrous tissue back here. So when we look in a minute at functional MR, it tends to be the posterior annulus that really dilates during degenerative functional mitral regurgitation. So what we'll do is we'll walk through a couple of the pathophysiologic processes and start with rheumatic mitral stenosis, which we don't see a lot, but as you know, is the most common cause of mitral valve disease in the world. And we still occasionally will see cases, either, most often people who have come over to the United States, but also people who are living in the United States and didn't have good access to care as children and had strep. So here is the classic findings. You get thickening of the leaflets at the edges. You have immobility of the posterior leaflet and doming of the anterior leaflet. And then commissural fusion. So this is a sort of the classic findings of rheumatic mitral stenosis. And here's an example of a case that we treated. So here's a 3D on fast view looking down the barrel of the mitral valve from the left atrium to the left ventricle. And this patient had a 10 millimeter mercury of mean gradient. This is what an NOA balloon looks like during expansion for a percutaneous balloon mitral valvuloplasty. And the idea here is that you split the commissures and get it back to relatively normal, at least functioning mitral valve. So the valve gradient came down to 5 millimeters of mercury. The valve guidelines were rewritten in 2014, so for the next two talks, we'll sort of highlight the changes and the basic algorithms for approaching patients with valve disease when it comes to mitral and aortic. So for rheumatic mitral stenosis, if it's very severe, which is less than 1 centimeter squared, and you're symptomatic and you have favorable morphology without exclusions or contraindications for valvuloplasty, you do a valvuloplasty. But if you have unfavorable morphology or contraindications to doing a percutaneous mitral valvuloplasty, and you're symptomatic and not high surgical risk, you get a mitral valve replacement. If you have those criteria, but you're high surgical risk, even though your morphology is not favorable, it's reasonable to consider a percutaneous mitral valve valvuloplasty. And this sort of highlights, I think, the importance of having a team approach. So a multidisciplinary team with cardiologists, cardiovascular surgeons, and interventional cardiologists who can all sit down together and come up with the best game plan for each individual patient. Because if someone's prohibitively high risk surgery, you don't necessarily want to have to take them to the OR because the interventionalist doesn't want to do anything. The interventional procedure, even if it's important to understand if the morphology is not favorable, that doesn't mean the risk is high. It means the likelihood of success is not as great. You can tear a valve even if it has a very favorable morphology. It's really an issue of success. And so having, everyone on the same page, and it's also important to have everyone on the same page because if you do tear the valve, you don't want to be sort of calling your cardiovascular surgeon blindly. You want him to be aware that you're doing the procedure, and if something goes wrong, I hope you're around so we can get this taken care of. Yes. Now that's very severe. Just for definition, severe mitral stenosis is defined as a valve area of less than 1.5 centimeters squared, and if it's symptomatic, it follows the same path as the very severe. The asymptomatics in both arms, whether it's severe or very severe, is a little tricky. If you're asymptomatic and you have favorable morphology, it's reasonable to do a valvuloplasty. The reason is, it's nice to do things when they're elective. If this patient now with severe mitral stenosis comes in with a hip fracture or some other non-cardiac issue that requires surgery, mitral stenosis is a very challenging lesion to manage when people are sick. And a lot of times it's even in young people. So when I was in New York, I was exposed to this as the first time as a young Chinese woman who got pregnant and all of a sudden came in with hemoptysis and had critical mitral stenosis, and that's a tough spot to be put in. And so if someone had gotten ahead of that and treated her up front, it wouldn't have been as challenging to manage someone like that. For the moderate mitral stenosis, so a mitral valve area of greater than 1.5 centimeters squared, if they're symptomatic and you can't really come up with any other cause, and they have some degree of pulmonary hypertension, particularly with exercise, it's again reasonable to do some intervention on the valve. But otherwise, if it's moderate and they're short of breath, but don't really have any upstream consequences like pulmonary hypertension, you would just watch and wait. And all mitral stenosis is obviously not rheumatic. Particularly these days, we see a lot of other causes for mitral valve stenosis, degenerative, calcific. We see a lot of this, particularly in little old ladies. Congenital, drug-induced radiation, we see quite a bit, particularly from the MD Anderson. And then iatrogenic, clearly, you can have patient prosthesis mismatch. There can be disruption to the mitral valve function. Sometimes in TAVR has been reported. And then with percutaneous mitral valve repair or mitral clips, one of the issues with mitral clips is balancing, getting rid of the mitral regurgitation and not inducing mitral stenosis. And we've seen a couple of patients with pretty severe mitral stenosis after a mitral clip. So here's an example of a radiation-induced mitral stenosis. So you can see the leaflets are really heavily calcified and the subvalvular apparatus is degenerated. So that's the most common, but probably the least frequently seen in this country cause of mitral valve disease. What's much more common and what you'll see a lot of is mitral regurgitation. And this slide sort of lays out in a schematic and then two-dimensional echo and 3D echo a normal here on the left, so papillary muscles, chordae, and leaflets. Here's a nice healthy mitral valve. And compare that to a prolapse here with posterior prolapse coming up here, and you see what's a P1 prolapse right here in 3D versus a flail. And this is a flail mitral leaflet cartoon, and here you see the posterior leaflet coming over the anterior leaflet in 2 dimensions, and here's what a 3D flail would look like. And here's a example of what we or Dr. Little would see in the echo lab. And you can appreciate here on color Doppler a significant amount. That one's not going to play, it's okay. Here you can see a significant amount of mitral regurgitation coming all the way back along the interatrial septum, and you would see reversal of flow in the pulmonary veins, which would help you quantify how bad the disease is. Here's a nicer picture on a TEE, again showing a nice prolapse and flail back here. Let's get to the next one. Here we go. So here is an overview of mitral regurgitation, chronic mitral regurgitation. For all these valvular lesions, acute lesions are sort of catastrophic. You know, patients present in florid heart failure, cardiogenic shock, and they just need to get fixed sort of ASAP, and they're very, high risk. It's the challenge in managing a lot of valvular diseases of chronic patients and timing, when to intervene. So for chronic mitral regurgitation, here's an entire list of the various etiologies, including the functionals, the degeneratives, and then, the other things that we see a handful of: rheumatics, endocarditis, the HOCMs, some congenitals, and drug-induced. But it's important to appreciate what part of the apparatus is being affected depending on the etiology of the disease. So you can see if it's a functional or an ischemic, it's the left ventricle and the papillaries and the annulus, versus the myxomatous degeneration, which is actually truly the leaflets themselves and part of the chordae and annulus. And that would sort of determine how you would want to fix the valve. And I think some of the data that we've seen recently, particularly in functionals, where replacing it is probably better than repairing it, it makes sense because it's not actually the leaflets themselves that's the problem in mitral regurgitation. They just need a new entire apparatus. So here's a cartoon going through the pathophysiologic stages of mitral regurgitation. So you have normal volumes, normal pressures, and normal cardiac output. When you get acute mitral regurgitation, you increase the left ventricular end diastolic volume, and a large amount of that volume goes back into the left atrium, and you increase your left atrial pressure, and obviously that's how you get your symptoms. But at the same time, you decrease your forward flow or your cardiac output. Now, in compensated chronic mitral regurgitation, you still have a significant amount of blood flow back into the left atrium, and you've really increased your end diastolic volume, but you've been able to maintain forward flow and perfusion. So there's lots of patients we follow in our valve clinic who have really severe torrential mitral regurgitation but are completely compensated. And the challenge is trying to figure out what to do with them before they truly decompensate, where their end diastolic volume gets really tremendous with really not much change here in the backward flow, but they lose their forward cardiac output. And so our challenge and yours is to try to figure out the timing when to intervene and how to intervene before people get that sick. Functional mitral regurgitation is a little bit of a different challenge because it's more than a valvular issue. It's usually a ventricular issue, as you know. So here's a cartoon showing the normal mitral valve with the chordae and paps. But during functional mitral regurgitation, you get displacement of the posterior medial papillary muscle and essentially restriction of the leaflets. And it's almost as if the cords are now relatively short because the ventricle has enlarged. So when we approach mitral valve disease, we go through sort of the following 4 steps. The first is we want to know, what's the etiology? Why does this person have mitral regurgitation? What was the timing? Is it acute or chronic? Obviously, acute is somewhat of an emergency. And then quantify it, and that's what Steve does in the echo lab. And then has the patient had any consequences, symptoms, pulmonary hypertension, atrial fibrillation, et cetera? And at that point in time, we should intervene. So here's the, again, updated guidelines for mitral regurgitation intervention. And it says here mitral valve repair is preferred over replacement when possible, although I would argue in functionals, there's data now to show that mitral valve replacement may be a little bit advantageous over mitral valve repair. Be that as it may, with mitral regurgitation for primary degeneratives, it's pretty simple. If it's severe and they're symptomatic and they have a preserved EF, they go for surgery. If the EF is bad, I mean, if you have an EF of 15 to 20%, then you can still operate, but it may have been, we lost our opportunity to intervene up front. You might want to get your heart failure colleagues involved. Asymptomatics are a little bit tricky. If you're asymptomatic and you have severe mitral regurgitation with a preserved or an injection fraction between 30 and 60%, but a little bit of dilation during end systole with a diameter of greater than 40 millimeters, that is a class 1 indication to intervene and do surgery. So there are asymptomatic people out there who we should be referring for surgery, and we do, who are starting to show signs of some consequences from the lesion. If you're asymptomatic and you have a normal ejection fraction and your end systolic dimensions less than 40, but you have a very high likelihood of a repair with a low risk, it's also reasonable to refer that patient to surgery. If you have new onset atrial fibrillation or pulmonary hypertension, in the same story here, again, it's reasonable to refer to surgery. So this is the tricky group, because I think this is where we sometimes miss an opportunity to intervene earlier on rather than allow things to degenerate in the ventricle to subsequently suffer its consequences. If you have obviously moderate mitral regurgitation, we just monitor it usually every 6 months with an echo. Functional MR, the recommendations are mostly to treat medically as possible, treat the coronary disease, treat the heart failure, consider resynchronization therapy. And as we've seen from participating in the COAP trial, I mean, a lot of these people, their mitral regurgitation gets better. I mean, they come in with severe MR, decompensated heart failure, you get them on good therapy, you get them resynchronized, and the MR is mild. But if you've done all that, and it's still severe and symptomatic, and they have heart failure, surgery is really probably their best option. But if they're asymptomatic and you've got them on therapy, you can continue to watch them.